This should be very interesting and easy. A 40-year-old with fatigue and edema, echo shows normal left ventricular size, impaired diastolic filling, very important clue. So the blood is not going in, maybe the space is less. Okay, this is how I would want to think about it. Okay, biatrial enlargement. Okay, so the atria are in. Okay, let's see endomyocardial biopsy. So you should be very happy when they give you biopsy findings because biopsies can tell you everything, right? Apple green birefringence under polarized light. This is very specific for amyloidosis. Okay. So apple green birefringence under polarized light gives you a direct diagnosis of amyloidosis. But now, of course, the amyloid deposition has occurred. What do you know as a connection between cardiomyopathy and amyloidosis? Okay, that is what I would want you to learn today. Okay, is there any connection between cardiomyopathy and amyloidosis? Okay, I would want you to think. Okay, uh, let's look at that connection. So, restrictive cardiomyopathy is a situation where the heart walls, the ventricular walls, are stiff. So that this is the connection. So, what has made those heart walls stiff and they are unable to expand? The heart is unable to relax because the heart is unable to expand. The walls are unable to relax fully. Less blood goes in. So, this becomes a diastolic dysfunction, isn't it? So, less goes in. Uh, we also have these topics on restrictive, obstructive lung diseases. So restrictive heart disease is somewhat similar, where in the lungs less air goes in, less comes out. You remember we talked about that. In this case, also it's a similar thing. Less blood is going in the heart because the heart cannot expand or relax. The compliance is lost. We say the same thing for the lungs. In restrictive fibrotic diseases of the lung, the compliance is lost. It cannot expand or relax. Same thing has happened here in the heart. This is a heart with rigid, non-compliant ventricles. Look at the description, same words, right? Which may be able to contract normally. So contraction is not a problem, but relaxation is a problem. Okay, that is why I said less goes in, but ejection fraction could be normal because contraction isn't a problem. The percentage in every contraction that comes out, that pushes the blood out is sort of in the normal percentage range. Okay, it could be less in volume, but percentage wise, it is not less. Okay, it may be, like I said in the beginning, 100 ml and normal should be 65 ml. In this case, it probably is 50 ml going in. Okay, and it's again sort of 30 ml coming out. Okay, so going out of the heart. So percentage wise, it isn't less. Okay, but overall the amount of it's we don't need 30 ml, for example. We need 65. Just giving you these numbers and examples so that you can understand and imagine what's happening in here. So systolic function is normal, ejection fraction is normal, but cannot fill correctly because of rigidity. So this is diastolic dysfunction. And I would want you to learn the causes for restrictive cardiomyopathy. So number one is post-radiation fibrosis. Okay, so radiation causing fibrosis, that is what is making the ventricles stiff and cannot expand or relax. Loeffler's endocarditis. So Loeffler's is that disease with a lot of eosinophils, can also lead to disease in the lungs and other tissues and heart here, right? Endocardial fibroelastosis. So this is a thick fibroelastic tissue in young children, again, making the heart difficult to expand. Amyloidosis, we just saw the question. Sarcoidosis, okay, immune disease. Hemochromatosis, again, iron, any deposit, copper, iron deposit in in the heart wall can make it stiff, can make the heart walls very rigid, and they cannot expand fully. So diastolic dysfunction ensues, and this person can have a low voltage ECG despite thick myocardium. And this is what happens in amyloidosis because the heart is not expanding and the walls are thick. Loeffler's endocarditis, mentioned, this is the hypereosinophilic syndrome, right? And histology would show you eosinophils in this case. So even in the lungs and other systems where you have these Loefflers. Okay, so Loeffler is more eosinophil, so same thing here. So connections, again, these connections are important. So Loeffler, eosinophilic, and then leads to some fibrosis, and it's going to make the heart walls very, very stiff. Okay. One more thing with amyloidosis, if we have a minute more, I think we can continue from here next Sunday. But just showing you one thing uh, before we end our lecture today. So senile cardiac amyloidosis. So senile cardiac amyloidosis is a deposit of transthyretin, which leads to that restrictive type of cardiomyopathy. Okay, so this question was asked recently around heart failure in an elderly person. Nothing else was given, and everything was ruled out. There is no history of anything, no drug, no alcohol. Like there is nothing, no history of coronary artery disease, no atherosclerosis. They ruled out everything. So basically, no apparent cause, and still the person is having a heart failure. What could it be? It could be amyloidosis. Okay, transthyretin deposition.